below 1,000 grams. It may still be seen as many as half of all infants who are less than 600 grams birth weight. Bone mineralization occurs primarily in the third trimester. Notice that the third trimester, when a baby is intrauterine life, accretion rate of approximately 120 to 150 milligrams of calcium and around 75 to 85 milligrams of phosphorus per kg per day. Here in this slide, as we know, there's a major changes, or a lot of things has been happening during the third trimester when a baby gaining weight, estimated gaining weight more than 3-fold, and the calcium and phosphorus acquisition here more than 4-fold. When the calcium and phosphorus came together here, they will form the hydroxyapatite, which is the backbone of the bone, and that require an adequate nutritional supply. So in case if we're having unhealthy placental or inadequate placental or inadequate placental blood supply, like in case of IOGR or chorioamnionitis or preeclampsia, so we're expecting that this physiological event won't be happening in the third trimester. So in the fetal life, there is a preferential shunt from mom to the baby of minerals. Is the estimated ratio 1 to 1.4, and that make the skull well developed during the fetal life. And this process happening by the help of parathyroid-related peptide and possibly by parathyroid hormone. What's happening in postnatal? Postnatal, there is hormonal change that decrease estrogen and increase in parathyroid hormone. There is loss of in utero mechanical stimulation, and there is low of mineral content of human milk coupled with relatively inefficient absorption of developing gut. Here's the different etiology, many etiology like diet low in mineral content and supplemented human milk or unfortified milk, long-term use of parenteral nutrition, formulas not designed to use in infant like soya bean or lactose-free, furosemide therapy, long-term steroid use, and vitamin D deficiency is not a major factor for metabolic bone disease or prematurity, but may be ideal to maintain a 25 hydroxyvitamin D level more than 50 nanomole per liter. So here's a bit risk factors also for the estival prematurity with low gestational age, like feeding practice, delayed enteral feeding, drugs like corticosteroid, loop diuretics, vitamin deficiency in case of exclusive breast milk without any fortification or mineral supply, prolonged immobilization, also a risk factor for those who are very low birth, and aluminum containing parenteral nutrition like in case of PPI and ranitidine supplement. Necrotizing enterocolitis here also is very important in case of premature baby. Here's a common medication which we are using in our units that having risk factors for baby, and we have to be cautious and we should monitor the baby frequently in case he is on long course of corticosteroid like DART protocol for bronchopulmonary dysplasia. They found that corticosteroids inhibiting osteoblastic activity, increase osteoclast activity, and increased resorption at the same time decreased bone formations. Loop diuretics leading to excretion of calcium and phosphorus at the same time increase bone resorption. P453A4 inducer, the most common anti-epileptic medication we are using in the NICU, which is phenobarbital, lead to induced metabolism of vitamin D and decrease the level and increase resorption and decrease bone formation. TPN also having a role here that whenever it's suboptimal supplied with calcium and phosphorus and containing aluminum content, most of the TPN preparation having aluminum content, and that lead to increased resorption, decreased bone formation, and decreased bone formation. Typholine caffeine also lead to increased bone resorption, and anticoagulant medication also lead to decreased bone formation. Here, when it comes to vitamin D, all we know that vitamin D as a protein relating to the sun, but for preterm in a unit, mainly dependent on breast milk and preterm formula and fortified milk supply. So when we look to the pathway here, when the cholecalciferol will be converted to, cholesterol, biosynthetic cholesterol will be converted to cholecalciferol, vitamin D3, with a supplemented formula to deliver the 25-hydroxyvitamin D is hydroxylated from the liver. And again, one more, it will be converted to the active form, 125, that maintain calcium balance in the body activity. So here, when we are sending to the lab, it depends on the lab. Either he will get us vitamin D2 or vitamin D3, but we are caring mainly on total vitamin D level in order to monitor the baby. And we are always, all the time, measuring that 25-hydroxyvitamin D3 because it's having long-acting in comparison to 125, which is the active form, having short-acting life. This is in spite or regardless of the gestational age, with the continuous minerals requirement. At birth, they notice that the calcium level here is at birth will be decreased. At the same time, whenever calcium level is decreasing, lead to a stimulation of the receptor for the parathyroid hormone. Parathyroid hormone here having a role to activate 1-alpha-hydroxylase. 1-alpha-hydroxylase role is to convert 125-hydroxyvitamin D to the active form. So the active form 125-hydroxy having a direct biological role in the gastrointestinal tract to lead to calcium absorption and phosphorus absorption. At the same time, the parathyroid hormone will go to the bone and stimulating the osteoclast to release phosphorus and calcium, and the kidney lead to increasing calcium absorption but phosphorus excretion. So this is a brief histology to make you understanding what's going on in metabolic bone disease. So how this disease is presenting, characterized by bone that is under mineralization or called washed out bone. Signs of ricket, either epiphyseal dysplasia and skeletal deformation, usually become evident after 6 weeks postnatal age or by term corrected gestational age. The risk of bone disease is greatest for the sickest and the most premature infants. So we have to be careful for these groups. Again, the history, they are below 26 weeks or 800 grams or less. Prolonged parenteral nutrition, long-term steroids is very common. A rapid increase in alkaline phosphatase value is common also. A history of fracture noticed by caregiver or incidentally on X-ray taken for other purposes. On the physical examination, infant with the metabolic bone disease demonstrates few symptoms or signs until late into the disease. So this ranging from respiratory insufficiency or failure to wean from the mechanical ventilator, hypotonia, pain on handling due to pathological fractures, decreased linear growth with sustained head growth, frontal posing, enlarged anterior fontanelle, and widened cranial sutures. What is in our laboratory studies? The earliest indication of osteopenia are often a decrease in serum phosphorus concentration, at the same time increase in the alkaline phosphatase activity. The serum phosphorus level less than 1.8 millimole associated strongly with radiological evidence of rickets. Alkaline phosphatase increase over the third trimester over the first 3 weeks of life and reach peak at 6 to 12 weeks of age. Alkaline phosphatase above 500 international unit is suggestive of impaired bone hemostasis, and value of above 700 are associated with bone demineralization despite the absence of clinical signs. A combination of serum phosphate level less than 1.8 millimole and alkaline phosphatase level above 900 in preterm infant who are less than 33 weeks indicate a low bone mineral density and has a sensitivity of 100% and a specificity of 70% for metabolic bone disease. So we should be careful whenever we are monitoring or reviewing our results data for the babies for alkaline phosphatase and phosphorus. Serum alkaline phosphatase level is often but not invariantly correlated with the disease severity, but if it is above 1,000, so we have to suspect the severity or severe rickets. A normal unit range of alkaline phosphatase is much higher than in adults. A value of 400 and 600 are commonly in very low birth weight infant with no evidence of osteopenia. Serum calcium level either will be low, normal, is not a good indicator of the presence or the severity of metabolic bone disease. It is often maintained normal despite of the metabolic disease, as we discussed in the slide, with the help of the parathyroid hormone. Serum 25 hydroxy vitamin D level do not need to be routinely assessed in preterm infant. Optimal level in infant are unknown and as are functional outcome at any level. When assessed, the target of above 20 always needed are reasonable based on a very limited evidence. There is no evidence that level of 12 to 20 nanogram per ml lead to worsened osteopenia in preterm infants. So we are mainly monitoring the phosphorus and the alkaline phosphatase initially. An elevated serum parathyroid hormone level may be indicative of osteopenia. Elevated parathyroid hormone level not only indicates secondary hyperparathyroidism, but in association with kidney tubular absorption of phosphate can also differentiate the underlying cause of hypophosphatemia. A high parathyroid hormone level with low TRB, total reabsorption of phosphorus, the normal range is 75 to 85 for TRB, indicate calcium deficiency, while a normal or low parathyroid hormone with high TRB indicate phosphate deficiency. Urinary biomarker. A measurement of TRB is an important second-line investigation. The normal range of TRB is between 75 to 91, and value of above 95 is a significant marker of insufficient phosphate supplementation. Tubular reabsorption formula here we can show. You can do a Google and just get the ready calculator for this formula after you're getting all the lab results, and you will get the final results accordingly to their analyzing data. Imaging. We have radiographic signs on X-rays like widening of epiphyseal growth plate, cupping, frying, and rarefaction of the metaphysis, subperiosteal bone formation, osteopenia, particularly of the skull, spine, scapula, and ribs, occasionally some osteoporosis or pathological fractures. Here we can see a normal X-ray for the baby, but here we can see the early changes in the left upper screen, the B of bone demineralization. You can see in the humerus. Here is typical presenting rickety changes of the bone, where the bone formation after fracture or healing process. Here also again the healing fracture for the baby with the cupping and frying of the epiphysis. A loss of up to 40% of bone mineralization can occur without radiographic change. So be careful. Not always you will find the radiological changes for the preterm baby, and don't wait till the radiological changes come in the X-ray. Just follow your lab investigation and start the proper management. Just formation of changes. This is the most active part in the body. So why we are relying on it all the time on X-ray. Measurement of bone content by densitometry or ultrasonography remain investigational in preterm infant. Dual energy X-ray absorptiometry, DEXA, is a good standard, a gold standard technique to assess bone metabolic disease adaptable in preterm infant. It expresses the bone mineral content and as a gram of hydroxyapatite per centimeter squared. DEXA value are a function of the size of the bone being measured, its volume, and its density. So what is the management of this disease? In case of primary phosphate deficiency, low phosphorus for age, and normal plasma parathyroid hormone level, phosphorus supplementation can be initiated in the dose of 0.5 to 1 millimole per kg per day and 2 to 3 divided dose.
Hello, we cannot see the lecture and we cannot hear you.
Yes, same for us also.
Dr. Yaman, Dr. Ahmed, we cannot hear and we cannot see any lecture.
الشغلة بالنسبة لي في البريتين بالتالي بتاع الإلكترونات لأنه إحنا ما عندنا بتاع المينرال كالسيوم فوسفورس. So in which sense they are same أي وحدة في السيستم لأنه دي بتدينا النورمال فاليو ما بتورينا
No?
ولا هم بيتبعوا بتاع البريد.
إذا كان ظاهر ما جاب ولا ما بدوا هم. يا شيخ. دخلنا وطلعنا اللي بتخلفها.
أنا بالأول ما كانت دكتورة أنا كانت موجودة
وصلت وين؟
هنا ولا فوق؟ صح؟ اوكي.
On the equation, Dr. Yamin, on the equation.
Equation. Okay.
Yes, we stop on the equation.
Yeah. Okay. Clear now?
Yes, we stop it here.
هاي؟
لا
ما تضغط.
هاي بس شوي لأنه بطيء فجأة.
هذا ليش طالع هنا؟ Okay. So this is the equation. I think we stop where we stop, and we continue for the imaging. Radiographic signs, including here widening of the epiphyseal growth blades, cupping, frying, and rarefaction of the metaphyses, subperiosteal newborn formations, osteopenia, particularly of the skull, spine, scapula, and ribs, and occasionally osteoporosis or pathological fractures, as in my case. Here is a different view for the first in the top of the right side. We have a normal X-ray, and here in the left upper top, we have the early changes of metabolic bone disease. That we can see bone demineralization and some osteopenic bone reaction in the epiphyses. Here is we can see the rachitic bone changes and healing processes here, and some bone formation in the epiphyses. Here also we can see the healing fracture with the typical frying and cupping of the epiphyses with bone demineralization. So a loss of 40% of bone mineralization can occur without radiographic changes. So be careful here. You are not suspected or you are not expecting to see bone change earlier. Chest film may show osteopenia and some rickety change. Breast or knee film can be useful, and always we are asking for this view because the most active part in the babies. Generally, if marked abnormality are present, film should be obtained again by 4 and 6 weeks later after the clinical interventions. Measurement of bone mineral content by densitometry or ultrasonography remain investigational in preterm infant. DEXA, which is the dual energy
Again, Dr. Yamen, there is no sound. We can see the lecture, but no sound.